Hypersensitivity pneumonitis is classified as an interstitial lung disease is characterized by a complex immunological reaction of the lung parenchyma in response to repetitive inhalation of a sensitized allergen. The name HP defines the disease more appropriately than the previous term, extrinsic allergic alveolitis, as the inflammation involves not only the alveoli but the bronchioles as well. The causative antigens in most cases of EAA, including the disease variant known as farmer's lung disease, are bacteria, the most commonly described being thermophilic actinomycetes. These species include Micropolyspora fini, Thermoactinomyces vulgaris, Thermoactinomyces viridis, and among others. All HP diseases, including EAA, are caused by repeated exposure to antigenic particles in a susceptible, previously sensitized patient. The characteristics of antigens that determine their ability to induce an immunological response include their size, solubility, nature of resistance to enzymatic degradation, and inflammatory capacity. These antigens are implicated in the formation of antigen-antibody immune complexes, particularly of the IgG type, which intervene in complement activation. Antibody response alone is insufficient to cause a disease. Hence, a cytotoxic CD8 plus lymphocyte response is also required. Immediate hypersensitivity reactions are probably caused by IgG4 rather than IgE, which play a role in the genesis of immunological response. The susceptibility is more common in middle-aged and non-smoker men, like the patient in this case, which is a 46-year-old farmer named Frank. As for laboratory diagnosis, no single test is specific for EAA, but symptomatic patients typically have findings consistent with pulmonary inflammation and systematic symptoms. Like other diffuse interstitial pulmonary diseases, the point of departure is clinical suspicion backed up by a detailed history of workplace and environmental exposure, suggestive clinical symptoms, and lung function values, radiologic findings, cytologic evidence, and consistent pathology results. The specific IgG precipitants, skin prick test, bronchial challenge testing, radiology, respiratory function, specific inhalation challenge, bronchoscopy, transbronchial biopsy, cryobiopsy, and surgical lung biopsy are the additional tests performed. The exact prevalence of EAA is difficult to determine since it is influenced by many factors including climate, geographical region, local customs, differences in the nature and the intensity of exposure to antigens. Approximately 0.5% to 3% of farmers develop EAA with variant FLD with associated higher mortal rates, which is a significant cause of morbidity among farm workers. Mild HP may also be misdiagnosed due to nonspecific findings. The incidence of HP among Swedish farmers, as reported in the Sweden Population Registry, is approximately 20 per 100,000 person years. Other European population registries report HP incidence at 1.5% to 12% of all interstitial lung diseases. Here in Asia, the prevalence is less than 6% as described in recent studies.
The patient's signs and symptoms. The patient is a male and 46 years old with no history of allergy. In his case, he had been experiencing malaise for about 18 months. He lost weight and had cough with blood and had a hard time breathing with constitutional signs of flu. All of his symptoms lead to extrinsic allergic alveolitis.
Upon examination, Mr. Frank's chest enlargement was symmetrically reduced, and there were some point and inspiratory concourse at the bases of the lungs. No lymph nodes could be felt, and there was no finger clubbing. His cardiovascular system was normal. Peak expiratory flow rate was measured using a peak flow meter utilizing simple lung function test, and it was found to be 380 per minute. A full blood count was normal, and the one-to test was negative. His physician advised him to consult a chest specialist for further advices. An X-ray of the chest was taken, and the middle and lower node zones showed bilateral reticulongular shadowing. The lung function test, also called pulmonary function test, showed a reduced forced expiratory volume in the first second. FEV1, a decreased vital capacity, a restrictive effect, and a 60% reduced capacity for diffusing carbon monoxide gas. Upon examination, Mr. Frank's chest enlargement was symmetrically reduced, and there were some point and inspiratory composed bases of the lungs. No lymph nodes could be felt, and there was no finger clubbing. His cardiovascular system was normal. Peak expiratory flow rate was measured using a peak flow meter utilizing simple lung function test, and it was found to be 380 per minute. A full blood count was normal, and the Monto test was negative. His physician advised him to consult a chest specialist for further advices. An X-ray of the chest was taken, and the middle and lower node zones showed bilateral reticulolongulار shadowing. The lung function test showed a reduced forced expiratory volume in the first second. FEV1, a decreased vital capacity, a restrictive effect, and a 60% reduced capacity for diffusing carbon monoxide gas. Precipitating antibodies test. Precipitating antibodies are present in up to 50% of asymptomatic farmers exposed to the antigen. For factors positively associated with positive precipitin reactions were size of farm, time spent in the barn, and the presence of a family member previously diagnosed as having a farmer's lung disease. And for positive precipitin reactions were not associated with any of the following were the use of silos, hay conditioners, or hay dryers, the presence of quantity of moldy hay, or the presence of respiratory symptoms. The next test is the intradermal injection of M-Phenol. Intradermal injection of M-Phenol antigen led to an Arthus reaction with exposure to moldy hay and precipitating antibodies to M-Phenol were present in its serum. The next test is the bronchoalveolar lavage. It is the most sensitive tool to detect an alveolitis in patients suspected of having HP, but is not always necessary, particularly in patients with convincing exposure history and typical high resolution computed tomography or HRCT findings. Some authors pointed out the uh, pathogenic, pathogenetic importance of mast cells in farmers' lung on the basis of their correlation with the activity of the disease, with the bronchoalveolar lavage lymphocyte counts, and with the markers of lung fibrosis. The next test is the lung biopsy. Lung biopsy is particularly crucial in the diagnosis of hypersensitivity pneumonia. Recognizing patients with chronic hypersensitivity pneumonia and hinges on recognition of a characteristic combination of interstitial pneumonia, bronchiolitis, and granulomatous inflammation. The last test is the immunofluorescence analysis of bronchial biopsy. Farmer's lung is caused by actinomycetes, and presence of actinomycetes antigen were seen in the alveolar spaces.
Based on the laboratory findings and symptoms obtained by Mr. Franks, he repeatedly inhaled anaerobic bacteria known as thermophilic actinomycetes which are growing on stored damp crops. This indicates that Mr. Franks developed a disorder called extrinsic allergic alveolitis (EAA), or also known as hypersensitivity pneumonitis (HB). It is a lung disorder resulting from repeated inhalation of environmental agents, including but not limited to fungal and microbial agents, agricultural dust or proteins, bioaerosols, and various reactive chemicals. The antigen thermophilic actinomycetes have long been implicated as one of the sensitizing agents in extrinsic allergic alveolitis, which causes coughing, dyspnea, weight loss, and airway obstruction, all of which Mr. Franks experienced.
Lung parenchymal inflation in HP is a combination of type 3 and type 4 hypersensitivity reactions. The offending antigen or the chemical agent initially triggers the immune complex mediated type hypersensitivity or the type 3 hypersensitivity reaction after initial sensitization. Hence, in acute HP, high titers of specific IgG antibodies can be detected or the precipitins can be detected in the serum. Continued exposure to the antigen shifts into a delayed type 4 hypersensitivity. It activates CD8 cytotoxic T cells, releasing chemokines that result in macrophage activation and granuloma formation. As the disease progressed to subacute and chronic HP, an exaggerated T cell mediated immune response is noted. This results in increased T cell migration and proliferation. The mechanism behind progression to fibrosis is not clearly understood. There is thought to be a shift to the increased Th2 response that promotes collagen and disposition of fibrosis. The individual differences in susceptibility to HP suggest a genetic link likely through a major histocompatibility complex or MHC class. Class 2, namely HLI and DR and DQ. Cigarette smoking seems to protect from developing clinically significant HP likely due to nicotine inhibiting macrophage activation and lymphocyte proliferation.
Based on the results, blood test results shows that Mr. Franks was tested positive for precipitating antibodies test. An Arthros reaction in intradermal injection of amphetamine had increased numbers of T lymphocytes and mast cells. CD8 plus cells predominate with increased expression of MHC class II antigens and activation markers in bronchoalveolar lavage. In lung biopsy, shows granulomatous infiltrates of mononuclear cells thickening of the alveolar walls with lymphocytic and plasma cell involvement. And in immunofluorescence analysis of bronchial biopsy result shows evidence for actinocyte antigen in the alveolar spaces.
Flexible bronchoscopy with bronchoalveolar lavage or BAL in EAA typically reveals lymphocytosis and low CD4 is to CD8 ratio. This is not diagnostic of EAA but only provides supportive evidence. Transbronchial cryobiopsy. Transbronchial cryobiopsy uses a cryoprobe to obtain a tissue sample that is larger than TBLB but smaller than a surgical lung biopsy. The diagnostic accuracy in diffuse parenchymal lung disease approaches that of surgical lung biopsy, but data in EAA are limited. Arterial blood cast test. In arterial blood cast test, the doctor examines a sample of blood that was typically drawn from an artery in your wrist. The sample is then measured for its oxygen and carbon dioxide levels. Once the diagnosis is made, the cornerstone of treatment is the eradication of the causative agent from the patient's environment. The condition is typically reversible if diagnosed early in the course of the disease, and complete antigen avoidance can be achieved. This is often very difficult due to social, economic, or occupational reasons. Complete antigen avoidance should be advised by whatever means necessary to prevent progression of disease and fibrosis. Even though corticosteroids are widely prescribed, these are no clinical trials that have shown a reversal of the disease in severe cases. Plus, long-term steroids also have serious adverse effects. Lung transplantation has been shown to have excellent medium-term survival in patients with advanced lung disease due to EAA.
The characteristic immunologic finding in EAA is serum precipitating antibodies directed against the specific offending antigen as identified by Australoni gel technique and other immunoassays. High levels of complement-fixing precipitating antibodies of the IgG and IgM are the serologic hallmark of EAA. They are believed to be markers of exposure rather than directly involved in disease. The presence of serum precipitants confirms the exposure to an antigen but can be detected in up to 50% of similarly exposed asymptomatic individuals. However, it is unclear if the antibody is involved in pathogenesis of the disease or is simply a marker of exposure. Yet according to Chicane and Roots last 1996, a patient with common variable immunodeficiency who was unable to make specific antibodies developed EAA. With this, the role of immune complexes are still unclear as skin reactivity induced by antigens may result in delayed reaction with antigen, antibody, and complement found on biopsy. However, immune complexes have not been found in serum or lung lavage fluid.
Acute lung injury is a syndrome resulting from a variety of causes that involves diffuse inflation leading to proteinaceous alveolar edema. The mechanisms involved in the injury are remarkably similar regardless the underlying etiology, leading to damage of both epithelial and endothelial surfaces. Scarred lung tissues had a hard time getting oxygen to the rest of the bodies. This strains the right side of the heart. It may lead to high blood pressure in the lungs called pulmonary hypertension, and in severe cases, it can cause irreversible lung damage or even death.
According to research, complete antigen avoidance decreases the recurrence and progression of fibrosis in patients with non-fibrotic HP or hypersensitivity pneumonitis, and may be associated with prolonged survival in people with fibrotic HP. Removing the antigen and treating the inflammatory process are essential in the progression of the disease, since chronic persistent inflammation appears to be one of the processes for lung fibrotic remodeling. Identification and full antigen avoidance are the basis of treatment. Patients should be strongly encouraged to avoid further exposure. Yet, the antigen is unknown in 40 to 50% of HP cases.
The incidence of extrinsic allergic alveolitis is lower in smokers than in non-smokers. Because nicotine is immunosuppressive, it could be at least in part responsible for the protection observed in smokers against EAA. The individual differences in susceptibility to EAA suggest a genetic link likely through major histocompatibility complex class 2, namely HLA-DR and DQ. Cigarette smoking seems to protect from developing clinically significant EAA, likely due to nicotine inhibiting macrophage activation and lymphocyte proliferation. Mr. Franks, a non-smoker, had a hard time breathing, experienced weight loss, and was coughing non-stop as compared to his brother who smoked 40 to 60 cigarettes a day. His brother worked with him in the farm, yet he hadn't experienced any of these symptoms. Cigarette smoking imparts decreased risk of developing clinically significant EAA. However, smokers who develop EAA have been shown to have a more severe course and higher mortality.